Hello learners, welcome to lecture 48. In our last session, we explored the case studies of successful reproductive and child health programs, learning how innovation, community participation and political will led to progress. Today, we take a more critical look at community-based RCH programs, examining the real-world challenges that hinder their effectiveness. But we will not stop at identifying problems, we will also discuss practical solutions to overcome these barriers. This approach will give us a balanced view of the difficulties and the strategies to address them in order to strengthen future interventions. Community-based programs are often the backbone of reproductive and child health service delivery. They are closest to the people, rely heavily on local participation, and are intended to ensure equity. However, these programs face several barriers, ranging from resource limitations to socio-cultural resistance. Unless these challenges are identified and addressed systematically, sustainability and impact remain compromised. Therefore, developing feasible solutions is critical for long-term success. The challenges facing community-based RCH programs fall into broad categories. Resource and infrastructure gaps limit service delivery. Workforce and training issues reduce program efficiency. Socio-cultural barriers create resistance to services such as family planning or institutional deliveries. Governance and accountability issues weaken program oversight. Understanding of these dimensions help us craft targeted solutions. To respond, invest in basics. Drugs, equipment, transport and reliable power so services actually work at the last mile. Strengthen the workforce with regular training, supportive supervision and timely payouts for community health workers. Use respectful counseling and work with local leaders to address myths and cultural concerns. Improve governance through simple dashboards, social audits and grievance systems so problems are seen early and fixed quickly. One of the most common barriers is resource limitations. Inadequate funding leads to shortages of essential medicines, supplies and outreach activities. Poor supply chains result in stockouts of vaccines or contraceptives. Limited health facilities in rural areas force families to travel along distances for basic care. Together, these factors weaken the trust and utility of community-based programs. Community health programs often suffer from workforce shortages. There are a few trained health workers to cover large populations, and those in place face overwhelming workloads. Irregular payment of incentives further demotivates them. Burnout is common, leading to attrition. Without a motivated and adequately staffed workforce, community-based programs cannot deliver effectively. To fix this, recruit and retain more workers from local communities, set clear workload limits, and ensure on-time payments. Provide regular training, supportive supervision, and simple digital tools to reduce paperwork and track visits. Offer safety, transport, and small recognition rewards to keep morale high so teams remain in the field. Even when health workers are present, gaps in training and supervision weaken performance. Refresher courses are irregular and training quality varies. Many workers are left without proper supervision or feedback, which hampers skill development. As a result, knowledge gaps persist and services may not meet quality standards. Capacity building remains a core challenge. A practical fix is the use of standard competency-based training with hands-on practice and regular refreshers. Pair this with supportive supervision, monthly field visits, simple checklists, and clear feedback focused on coaching, not blame. Provide job aids and easy digital tools so workers remember steps during real visits. Create peer learning sessions and quick drills for emergencies to keep skills stronger over time. Socio-cultural barriers significantly influence RCH outcomes. In some communities, myths and misconceptions create resistance to family planning. Like, for example, some people believe that vasectomy will cripple a person from sexual activities throughout life. Traditional preferences for home deliveries persist despite risks. Gender norms limit women's autonomy, making it difficult for them to access services without male consent. These barriers demonstrate how health interventions must engage with social realities, not just medical needs. Community participation is the foundation of these programs, yet in many cases it remains weak. Communities often see programs as government-led rather than their own. Local leaders may not be actively engaged, and many families are unaware of the entitlements under RCH schemes. Without true ownership, community-based programs fail to achieve sustainability. Governance challenges further weaken these programs. Accountability systems are often weak, allowing leakages of funds and inefficiencies. Corruption or mismanagement can reduce resources available for services. Poor monitoring and evaluation means problems are not identified in time, leading to persistent inefficiencies. Stronger governance is needed to address these systemic issues. Even when health workers are present, gaps in training and supervision weaken performance. Refresher courses are irregular and training quality varies. Many workers are left without proper supervision or feedback, which hampers skill development. As a result, knowledge gaps persist and services may not meet quality standards. Capacity building remains a core challenge. A practical fix is to use standard competency-based training and hands-on practice and regular refreshers. Pair this with supportive supervision, like monthly field visits, simple checklists, and clear feedback focused on coaching, not blame. Provide job aids and easy digital tools so workers remember steps during real visits. Create peer learning sessions and quick drills for emergencies to keep skills strong over time. Quality of care is often compromised in community-based RCH services. Overcrowded facilities, long waiting times, poorly maintained infrastructure, they discourage families from coming or seeking health care. Women may face disrespectful treatment during childbirth, deterring them from institutional care. Inconsistent standards across different facilities create further dissatisfaction. Addressing quality is critical for building trust and ensuring utilization, because quality maintenance in caregiving is very important for access and utilization of these health services. Simple fixes help. Adopt respectful maternity care and Lakshya standards. Create clear triage and queue systems, and keep delivery rooms clean and well stocked. Use checklists, regular audits, and community feedback like help desks, grievance boxes to spot problems early and act fast. Provide privacy, clean toilets, clean drinking water, and working referral transport. These basics quickly improve patient experience and encourage families to return. Referral systems are weak link in many community-based programs. Families face delays in referral due to poor coordination between facilities. Transport facilities are inadequate or too costly, leading to delays in reaching higher level care. Weak referral chains contribute to preventable maternal and child deaths. Strengthening this aspect is vital for comprehensive care. New challenges are emerging that further complicate community based RCH programs. Climate change and disasters displace populations and disrupt services. The COVID 19 pandemic revealed vulnerabilities in maternal and child health systems, with services interrupted for months together. Rapid urban migration has created growing slums where health needs are vast but service delivery is very weak. These challenges require adaptive strategies. To overcome resource limitations, governments and partners must increase funding for reproductive and child health. Supply chains should be modernized with digital tracking to prevent stockouts. Expanding of the rural infrastructure, such as birthing centers and primary health facilities, ensure equitable access. Investments in these areas are fundamental for strong and sustainable RCH programs. Addition of ring-fenced budgets for maternal and child health is very important so that funds are protected and reach the last mile on time. Use of simple stock apps, reliable cold chain fridges, for example with solar power where needed, and clear delivery schedules to keep medicines and vaccines available. Build and maintain roads, ambulances, toilets, and clean water at facilities. And set up quick repair teams so equipment does not sit broken. Finally, publication of spending and stock dashboards so communities can see progress and hold the system accountable. Workforce challenges can be addressed by recruiting more health workers and offering stable, timely incentives to keep them motivated. Providing career pathways where community workers can advance into supervisory roles builds long-term commitment. Recognition and fair treatment further enhances retention, reducing burnout and attrition. Training quality must be strengthened through standardized competency-based modules. Regular refresher courses keep the workers updated on evolving practices. Supportive supervision systems focused on mentoring and guidance rather than punishment ensures workers feel supported and confident in their roles. These investments improve service quality at the grassroots. And practical drills and case simulations so workers can practice real life situations. Use simple job aids and short e-learning videos to reinforce key steps between trainings. Create peer learning circles where workers review cases together and share tips, and link completion of modules to certifications and timely incentives to keep the motivations high. Socio-cultural barriers require sensitive, context-specific approaches. Community dialogues and health awareness campaigns can dispel myths and promote positive behaviors. Engaging religious and local leaders lend legitimacy to programs. Male involvement reduces resistance and ensures shared responsibility for reproductive and child health decisions. Community participation can be strengthened by revitalizing village health and nutritional committees and empowering women's self-help groups to take active role in planning and monitoring. Awareness programs should focus on informing families about their entitlements such as free services and incentives. When communities see tangible benefits, ownership naturally increases. Improving governance requires transparencies in financial systems and effective community monitoring mechanisms such as scorecards and social audits. Strong accountability frameworks ensure that resources are used efficiently and services are delivered fairly. When communities themselves are empowered to demand accountability, programs become more reliable and responsive. Promoting equity means designing programs that intentionally target marginalized groups. Outreach in tribal and remote areas should be prioritized. Urban health missions must address the growing needs of slum populations. Bridging the digital divide by ensuring affordable access to mobile and internet services will make digital health innovations inclusive. Adding of practical steps, use mobile clinics and community health camps, hire local volunteers and translators, and schedule services at times convenient for women and wage workers. Because going for health seeking makes these daily wagers lose the income of a whole day, which is very important as their livelihood. Track data by location, caste, tribe, gender, and disability to see who is being missed and fix gaps quickly. Provide materials in local language and disability friendly formats. Offer toll free helplines and grievance desks so underserved families can report problems and get timely support. Quality can be improved by training providers in respectful maternity care, upgrading of facilities to reduce overcrowding, and introducing standard treatment protocols across facilities. Patient satisfaction surveys can also help ensure that services meet community expectations. Better quality creates trust and improves health seeking behavior. Referral systems, they can be strengthened by introducing affordable transport schemes such as government subsidized ambulances, establishing emergency helplines, and improving coordination between community workers, primary centers, and higher facilities. Strong referral chains reduce delays and improve outcomes, especially for maternal emergencies. Emerging challenges require forward-looking solutions. Health infrastructure should be built to withstand disasters. Continuity plans must ensure essential reproductive and child health services remain available during pandemics. Urban health strategies should focus on the unique challenges of slum population, including overcrowding, poor sanitation, and limited access to care. Add practical measures. Design clinics with flood and heat resistant features, backup power, and emergency stockpiles. Keep serving continuity with clear duty rosters. Telemedicine, doorstep drug delivery, and referral hotlines. For slums, combine mobile clinics with water, sanitation, and hygiene upgrades, safe transport, and trusted community health workers. Use simple, real-time data maps to target the most crowded lanes first and monitor gaps quickly. Tamil Nadu's maternal and child health program provides an excellent example of overcoming challenges. By establishing a strong referral transport system involving communities in health planning and investing in infrastructure, the state has achieved impressive reductions in maternal and child mortality. This model shows how solutions can translate into measurable progress. The state runs round the clock emergency obstetric and newborn care with reliable ambulances and clear referral pathways. Facilities are better equipped, blood banks are available, and routine audits turn problems into fixes quickly. Community outreach and maternity tracking ensures women complete antenatal visits and deliver in safe facilities. Together, these simple, well-managed steps explain Tamil Nadu's steady improvements in maternal and child health indices. Rwanda, as we have discussed this in previous lectures also, overcame major barriers by introducing community health insurance, decentralizing health services to the local level, and strengthening accountability systems. These reforms improved equity and built resilience in health systems. Rwanda demonstrates that even resource-limited countries can achieve strong RCH outcomes through systemic solutions. They expanded services through local health posts and trained community health workers, so care was closer to every village. Community insurance keeps fees low, subsidized the poorest with simple renewal rules to maintain coverage. Community insurance kept fees low and subsidized the poorest with simple renewal rules to maintain coverage. Public scorecards and regular audits made providers answerable to citizens with improved quality and trust. This combination of local delivery, fair financing, and a strong oversight created steady gains in maternal and child health. NGOs, they often play a key role in developing and implementing solutions. They pilot innovative models that government later adopt. NGOs also support training and supervision of community workers. Their advocacy influences policy reforms that address governance and resource gaps. This partnership strengthens overall program resilience. The future of community-based RCH programs lies in integration with universal health coverage, ensuring sustainability and inclusiveness. Greater focus on equity will ensure marginalized groups are not left behind. Digital health innovations like telemedicine and mobile apps can make services more accessible, but only if implemented inclusively. To make this real, protect RCH services in insurance benefit packages and keep care cashless at the point of service. Design outreach specifically for remote, tribal, urban slum and migrant families with services in local languages. Use digital tools for appointment reminders, home visit tracking and e-referrals, but also offer paper or phone options so people without smartphones are not excluded. Regularly review data by poverty, gender and location to spot gaps early and fix them. To summarize, community-based RCH programs face multiple challenges in resources, workforce, culture, governance and equity. But practical solutions exist at both policy and grassroots levels. By strengthening systems and fostering community ownership, these two programs can achieve sustainability and lasting success in improving maternal and child health. In conclusion, challenges should not be viewed as obstacles alone, but also as opportunities for innovation and growth. By learning from these difficulties and applying evidence-based solutions, we can make community-based RCH programs more effective and equitable. Overcoming barriers requires persistence, partnerships, and political will. As we close, please reflect on how strong communities and resilient systems together can overcome the toughest challenges in reproductive and child health. Each problem presents an opportunity for creativity, collaboration, and renewed commitment. By working collectively, we can ensure that no mother or child is left behind. So this is all for module number 6. We close today with a closure to module 6. We'll start with the module 7 on our next turn, and it will deal with a very important topic of research and evaluation in reproductive and child health. And the first lecture for this module will be lecture number 49, which will deal with research methods in reproductive and child health. Thank you.